Hi, this is Dr. Brooke Patterson, and this week we will be looking at the reproductive system, which is often referred to as the genitourinary system because of the close proximity of the genital and urinary systems in the body. We do not include this within the performance standards for this course, but certainly it is the information that you will need in taking care of patients. It is also not usually a part of an inpatient assessment, but is done more often in the outpatient environment while you are doing a total health assessment of a client. We often tend to do more of a focused assessment of the reproductive or genitourinary systems as patients present with specific problems or complaints related to the system, which is one of the reasons why we cover it in this course, so you will be familiar with it. The functions of the genitourinary system really do focus on reproduction, sexual health, and on providing a drainage route for excretion of urine. As we discussed with our review of the other systems, the genitourinary system also interacts with other body systems. Problems with the urinary or reproductive systems can not only affect the systems shown here on this slide, but they can also trigger problems in other body systems. In addition, difficulties with these systems, genitourinary, can affect the patient's quality of life and sense of well-being. As a result, it's very important to remember that since the genitourinary system is predominantly involved in the sexual health of the individual and also elimination, it is a very sensitive area in which to discuss these issues with the patient. So it becomes important to protect the patient's privacy and confidentiality at all points during the assessment. In looking at the genitourinary system, I'm going to break it down into three separate components: the urinary assessment, the female genitourinary system assessment, and the male genitourinary assessment. We will start first with the urinary tract assessment. As with any system, the assessment begins with a collection of a comprehensive health history from the patient. It is important to establish a normal voiding pattern and frequency for that patient. We need to know how frequently they normally void. Is it a large amount? Is it a small amount? What does it look like? Have there been any recent changes in either their pattern, frequency, or the appearance of their urine? Have they had any past or current problems with urination? Perhaps they've had a history of frequent urinary tract infections. Maybe they've had kidney stones in the past. Maybe they have had frequent bouts of not being able to hold their urine, so that they have periods of incontinence. What factors have they found that influence their elimination pattern? For example, do they only have incontinence when they are exercising or when they sneeze or cough? Do they have more problems when they drink a lot of coffee or caffeinated beverages? What effect is this having on their daily activities? Certainly problems with the urinary tract system can markedly affect how a person's day-to-day activities occur. Many older adults, for example, are afraid to go about their activities because they are afraid that they are going to wet themselves or they are not going to be close enough to a bathroom when the urge hits. Family history can be important in assessing urinary tract because certain families have tendencies toward chronic urinary tract infections, renal disease, diabetes, or kidney stones. In collecting a pertinent health history, it is important to ask if the patient is experiencing any urgency, meaning that the patient has a sense that he or she must void now and cannot wait. Is there any dysuria or painful urination? Do they have any nocturia, meaning that they have to get up frequently during the night? And if so, how often do they get up? Is this a new onset or is it an increase in the usual pattern? Are they having any urinary retention? Meaning after they have finished voiding, do they have a feeling that they haven't emptied their bladder? Perhaps they feel that they might need to go, but they just can't. Are they experiencing any incontinence, like stress incontinence when they sneeze? Or simply they have an urge and they accidentally spill before they can make it to the toilet? Are they having any pain with intercourse, which could also be an indication of a urinary tract infection? The assessment techniques that are used in the urinary assessment include inspection, palpation, and percussion. RNs, though, basically focus on inspecting the urethral meatus for swelling, discharge, and inflammation. You may also palpate the suprapubic area for bladder tenderness or distension, but as RNs, we don't usually get involved in the percussion of the bladder or the kidneys. As I know you are already doing in fundamentals, assessment of the urinary system also includes the byproduct of that system, which is urine. It is important to be able to look at that urine and inspect it and to measure the volume to see that it is an appropriate amount, with most people voiding between 200 to 400 mils on a normal void. It is important to look at the urine for color and clarity and for odor. It should not smell funny, and it should smell like normal urine. Normal urine is yellow and clear. Abnormal would be dark amber to red. Hematuria, which is blood in the urine, which could be either clots or gross blood, and it should not be cloudy, have mucus or sediment in it. Next, we'll move on to look at the female aspects of the genitourinary system. As we talked about many times, collecting a full health history is very important in helping to set the stage for your full assessment, but particularly in evaluating the genitourinary system. This is a sensitive area, and not all patients are comfortable with the types of questions we need to ask or providing that very personal information. So you need to address these questions with professionalism and in a very confidential, private area so the patient knows that the information is being protected. It is important to ask questions such as if they are having any discharge, and if they are, have them describe it for you. Is it a milky discharge? Is it clear? Does it have an odor? Does it itch? Is there anything about that discharge? Perhaps it happens all the time, perhaps it only occurs at certain times. Has the patient noticed any lesions or rashes in their perineal area? Do they use douches or hygiene products, as these can create irritation or can create further problems? Do they have pain with intercourse or burning or painful urination that they need to tell you about? An important part of the female genital history includes a comprehensive menstrual history. It is important to ask the patient when their last menstrual period was. That's the recorded date when it first started, the pattern or the interval between cycles, and how long the cycles last. Do the patients experience any clots or pains? Do they have any symptoms either before or after they begin their menstrual cycle, or any time during their menstrual cycle that you need to document? Also, if they are approaching the end of their reproductive years, are they starting to experience any menopausal type changes or symptoms that are impeding their activities of daily living? Included in the health history is an identification of the type of contraception the patient uses. Not all patients totally understand contraception and how it's used, so it is important to understand if they know how to use it appropriately. We should try to gain an understanding of the sexual activity of the individual, their sexual orientation, frequency of sexual activities, and how many sexual partners they have had. Do they have a history of sexually transmitted infections? We will address a few of those a little later on in this lecture. If they have, when were they diagnosed? What treatment and what are they currently doing if they are currently at risk for transmitting a sexually transmitted infection to a partner? We should also ask if there is a history of any abnormal PAPs and or surgical procedures. It is important in any GYN history to obtain not only the patient's history, but also the family history, because many GYN problems, especially cancers, have a familiar connection. So it is important to determine if any primary relative, meaning a mother, sister, or daughter, has a history of breast, cervical, ovarian, or colorectal cancer, as this increases the risk of this occurrence for our patient. Most common female symptoms patients report include pelvic pain, which may occur during the bleeding cycle, in which case it is called dysmenorrhea, or it may be occurring at other times during the menstrual cycle. Abnormal bleeding that may occur between periods, after sex, spotting at any time during the menstrual cycle, bleeding that's heavier or for more days than was normal, or even bleeding that may occur after menopause. Patients may complain of vaginal burning, discharge, or itching. They may complain of lesions in the perineum, and they may have menstrual disorders such as amenorrhea, which means the absence of menstrual flow, or there may be significant changes in their menstrual pattern or flow. They may have urinary symptoms, such as we talked about previously, or they may have problems related with hemorrhoids or swelling within the perineum around the rectum. Although the majority of the assessment that you will do for the female genitourinary system is actually conducted through the interview process, when you are collecting the health information on the patient, it is important to understand the actual assessment techniques that are used. For the entry-level nurse, inspection is the primary mode that you will be using. Although advanced practice nurses also do a much more in-depth inspection and also do palpation. It is important in conducting any kind of genitourinary assessment that you maintain privacy and confidentiality throughout the exam to protect the privacy of that patient. The female pelvic exam is very often conducted as a part of a woman's annual gynecological exam or well-woman exam. This exam is actually more comprehensive because it actually serves for many women as their annual physical, and it includes their vital signs, assessment of their thyroid, heart and lungs, breast, abdomen, and pelvic exam. Inspection of the patient usually involves a generalized inspection of the perineum. It is very often done when we are giving the patient a bath because it is a very comfortable way of doing this in a non-intrusive fashion. Normally, when you look at the external genitalia, we are looking for the color, hair distribution, and the general condition of the skin. We should not see any unusual lesions or masses. There should not be any unusual odor. If there is a discharge present, it is important to be able to note the type of discharge because the type of discharge is highly suggestive of the type of organism causing the discharge. For example, a green-gray type discharge is indicative of trichomonas. A green or yellowish discharge is highly indicative of gonorrhea. A gray or white discharge is indicative of chlamydia. And a cheesy type discharge is very often an indication of a yeast infection in a female, which is fairly common and you will see frequently because the patient will complain about not just the cheesy discharge, but also of itching and perhaps burning. You might also see pubic pediculosis, which is pubic lice. When you are doing your general exam, you should see nothing protruding from the vaginal orifice. On occasion, the vaginal wall of the uterus may collapse, and you may actually see it protruding out of the vaginal orifice. This is unusual, but it does occur, particularly in older individuals. You will also inspect the rectum and note any hemorrhoids or lesions. The Pap smear is a screening test for cervical cancer. These guidelines are ever-changing, and the recommended frequency sometimes differs between guidelines. According to the American Cancer Society, Pap smears should begin 3 years after the female becomes sexually active, but no later than the 21st birthday. Risk factors specific for cervical cancer include HPV, or the human papillomavirus, which accounts for 95 to 100% of cervical cancers being related to the HPV infection, which is now one reason that we are now encouraging the HPV vaccine. Smoking has also been found to increase your risk for cervical cancer 2 to 4 times. The most important risk factor for cervical cancer is A, early sexual activity, B, nutritional status, C, smoking, or D, infection with high-risk strains of HPV. The answer is D, infection with high-risk strains of HPV. All choices are risk factors, but the most important is an infection with a high-risk strain of HPV. Now let us look at assessing the male genitourinary system and what components would be involved in that assessment. Pertinent health history would include any history of chronic diseases. Diseases such as diabetes, hypertension, neurologic impairment, respiratory problems, and cardiovascular disease all impact the genitourinary system and increase the risk for erectile dysfunction. Family history becomes important in testicular cancer, prostate, and penile cancers, as an incidence of these in a brother or father increases the risk for your patient. Infertility and history of hernias also have a genetic connection. You will ask about the past medical and surgical history. Has the patient had any surgeries performed to his penis, scrotum, or rectum? When was the procedure performed and how has it affected the patient since the procedure? What is the patient's history of sexually transmitted infections? Have they ever been treated? If so, what type of sexually transmitted infection? Have they had any injury to the pelvic region that may affect that? Did they have any prostate problems? This becomes particularly important as the patient ages. Sexual history would include things such as sexual orientation, number of sexual partners, and whether or not they practice safe sex. Medication usage is also important to include not just current medications that may be prescribed, but also herbal medications, recreational drugs, and over-the-counter medications, as they may have an impact on the genitourinary system and its function. Common genitourinary systems experienced in the male would include pain in the lower abdomen, pelvis, or rectal areas. Very often this is referred pain. For example, sudden distension of the ureter or the bladder may result in flank pain. Kidney stone pain may radiate down the spermatic cord and present as testicular pain. Pain in the groin or scrotum may result from a hernia or problems in the spermatic cord, testes, or prostate. It is important to find out what makes the pain better or worse, and if it's associated with nausea, vomiting, fever, abdominal distension, or burning on urination. Penile discharge, lesions, or rashes could warrant further testing for sexually transmitted infections. Assess the discharge as to whether it is continuous or intermittent. Bloody penile discharge is most often associated with a neoplasm. Sexually transmitted infections very often result in a yellow, milky white, greenish discharge or may not have a foul odor. Prostate problems usually result in problems with urination. As the prostate grows, it blocks the ureters and then creates urinary problems. Scrotal enlargement may or may not be accompanied by pain. Any patient with scrotal pain should be presumed to have testicular torsion until this diagnosis can be proven otherwise. We also need to assess for any impotence or erectile dysfunction and/or painful erections. When conducting a physical exam on the male GU system, this will most likely take place during a bath, assistance with toileting, or if the patient is experiencing any pain or complaints. You will inspect and palpate depending on the complaints and location. The exam could change depending on if the patient is circumcised. If the patient is not circumcised, you may need to retract the prepuce to inspect the glands. You will check the base of the penis surrounding the meatus to check for any lesions or discharge. You may need to check the skin behind the scrotum. Check the inguinal areas for any hernias or bulges, and the scrotum for symmetry, any edema, pain, cysts, or lesions. You can also palpate the bladder for distension and/or tenderness and inspect the rectal area for hemorrhoids or possible fistulas. Two common terms that are abnormal findings would be hypospadias, which is a congenital displacement of the urethra that you may determine at birth, or hydrocele is a collection of fluid around the testicles and is usually not problematic. Another term that you may encounter is varicocele, which is a dilated tortuous varicose vein most often affecting the left spermatic cord, which is longer and inserts at the right angle to the left renal vein. It is fairly common in young males and is the most common cause of infertility, so it becomes very important for nurses to screen for varicoceles in early adolescence. It is detected most often when the patient is standing. The nurse can palpate a soft, irregular mass that feels distinctly like a bag of worms posterior and superior to the testes. Another term you may hear is BPH, which is benign prostatic hyperplasia. It is an enlargement of the prostate that most often occurs with age, with 90% of males being affected by age 70. The enlargement of the prostate obstructs the urethra and interferes with normal flow of urine. The symptoms involve urinary frequency, retention, hesitancy, dribbling, nocturia, and incontinence. Treatment options are available if symptoms become problematic. Besides BPH, it is important to understand the two most prevalent types of cancer that are identified in the genitourinary evaluation of the male. The first is prostate cancer, which is the most common cancer among men. It is often associated with advanced age, with the most common age of diagnosis being 70. It is usually a very slow-growing cancer, and the age of the patient and symptoms will influence the actual treatment or intervention that is provided. Risk factors are extremely important in the occurrence of prostate cancer, with a strong familial history being paramount for brother, father, or son. There is an increased occurrence depending on your ethnic origin. African Americans and African Caribbean males are high risk. The signs and symptoms usually occur or present with urinary symptoms first. Very often, they also report an enlarged, hard, or fixed prostate, and patient may also present with complaints of back pain. The second cancer we need to address is testicular cancer. It is often referred to as a young man's disease because it is the most prevalent cancer in young men. It predominantly occurs and is most prevalent between the ages of 15 and 35. It is a highly curable cancer even if it spreads beyond the testicles. Risk factors include an undescended testicle, even if the testicle was treated to protect the fertility of the male, a family history of testicular cancer, the age of the patient, and race and ethnicity. I've listed the symptoms of testicular cancer here. It is important to understand that it can affect not just the size, shape, or feeling of the testicles or scrotum, but it may also affect the breast with some enlargement or tenderness in the breast area of the male. They may also have a generalized complaint of unexplained fatigue or generally just not feeling well. Testicular cancer usually affects only one testicle, so you usually will see that problems are associated with that testicle or scrotum. Self-exam, like the breast self-exam, is one of the best lines of defense against testicular cancer. We need to work with our patients to teach them how to do this exam effectively so that they are able to detect changes month to month that may occur, be able to identify and seek intervention when needed. The testicular self-exam is best performed after a warm shower or bath in which scrotal skin is warm and relaxed. The exam is done in a standing position. The client should gently feel their scrotal sac to locate the testicle. Hold the testicle with one hand while firmly but gently rolling the fingers of one hand over the testicle to examine the entire surface. And then you repeat that on the other testicle. Normal findings should find that the testicle should feel firm but not rock hard. It's not unusual for one testicle to be slightly larger or slightly lower than the other. Abnormal findings would include a small hard lump that may feel like a pea. It may not be tender. It may be accompanied by an enlarged testicle. It might be a change since the last monthly exam and may include swelling of the inguinal lymph nodes that may be not just swollen but also tender. Dysuria, nocturia, and dribbling are all symptoms commonly associated with A, BPH, B, hydrocele, C, inguinal hernias, or D, STIs. The answer is A, BPH. BPH, or benign prostatic hyperplasia, is a benign enlargement of the prostate. This restricts the urethra and the patient may experience dysuria, nocturia, and/or dribbling. We talked throughout the lecture about the impact of STIs, but I wanted to take a minute to talk about common risk factors and also to identify some common STIs. Engaging in sexual relations with new or multiple partners increases STI risk. A personal history of STIs often puts you at risk to develop further STIs, or engaging in sexual activity with a partner who has a history of STIs. Drug use and also a failure to practice safe sex and use a condom or protection also increases risk. Common STIs you may see are syphilis, which very often presents as a chancre or single painless ulcer. Herpes normally presents as multiple painful vesicles. Notice they are painful, whereas syphilis is painless. Genital warts, often resulting from HPV, may be seen, and you have pictures of these in your book so that you can refer to them so that you can visually associate these terms with what you see in the picture shown in your book. Penile cancer, although more rare, is a painless ulcer that fails to heal, and there's a good picture of that in your book as well. If you have any questions related to the information presented within this lecture, please let us know. Thank you.